Okay, I'm delighted to welcome you to our very special grand rounds today, and also want to welcome our residents in their traditional back of the room seating. So thank you. And today, introducing our speaker is Dr. Mihaela Teodorescu from the Division of Pulmonary and Critical Care and Sleep.
All right. Good morning, everyone, and thank you all for coming. Happy Veterans Day just ahead for tomorrow, and to those among you who served, thank you for your service. Honored today to introduce Dr. Christine Sinsky, who's the Vice President of Professional Satisfaction at the American Medical Association, a general internist. She practiced for 32 years at Medical Associates Clinic in Dubuque, Iowa. She's a former director of ABIM and a former director of ABIM Foundation Board of Trustees. She currently serves on a very important initiative of the National Academy of Medicine's Action Collaborative on Clinician Wellbeing, which released already its first report about a year and a half ago. At the AMA, Dr. Sinsky leads initiatives to improve opportunities for joy, purpose, and meaning in work for physicians and their teams. She also collaborated in research concerning the prevalence, drivers, and solutions to physicians' burnout, as well to creating resources for individual physicians and healthcare systems. Among them, a highlight, I believe, is the Steps Forward Academy, which I highly recommend to take a look, which is a set of practical toolkits on initiatives, implementation strategies, as well as progress assessment. Among her multiple publications, highlights are the Quadruple aim, texting while doctoring, and creating a cockpit, a manageable cockpit for clinicians, as well as Joy in Practice, which I highly recommend. And they all have contributed to particularly the recent national conversation. I had a privilege to work with Dr. Sinsky just about a year ago in a similar year and a half long initiative at the American Thoracic Society, and I was inspired by her embracing the fact that reducing burnout among providers is essential for high quality patient care and for a sustainable healthcare system. And I'm looking forward to her talk today on how to build on the foundational relationships of the system towards achieving that goal. Dr. Sinsky?
Thank you so much. Yes, thank you so much. And I had the pleasure of reenacting PTSD from 42 years ago this morning as I was downstairs in the cafeteria to get a glass of water and trying to find my way back. And so I remembered all of those sensations being a third-year medical student when the medical students didn't have a clue about anything. The residents were brand new to the facility. We were all in, I suspect, July of 1980 or so, walking around here having no idea where we were. And teams of 10 white-coated individuals would get to the bottom of the stairwell and have no idea where we'd ended up. So thank you for that opportunity to revisit that part of my past. And as you said, indeed, if you care about safety, if you care about quality, if you care about the financial sustainability of our healthcare system, then you have to care about burnout. We have a profession where we are privileged to work in work that is as meaningful as any work can be. And if over half of our colleagues are experiencing burnout, then we know the problem is not the individual, but it's the environment in which we live and work. And we know that 63% right now of physicians are experiencing some sign of burnout. And it's not because of individual weakness. It's not because of a lack of resiliency. In fact, we know that physicians are more resilient than the general population. So again, the concept is we need to fix the environment, fix the workplace, not fix the worker. So this, I think, is for you. I'll let you take a look at it. What we'll be talking about today, some brief introductory thoughts around burnout, and then we'll go through 8 different systems levels approaches to strengthening relationships as a means of reducing burnout. And when I suggest these examples, they are to stimulate your own thinking of ideas that you can adapt and adopt into your environment. But I'd like to start with what I've observed over those 40+ years since I was a lost medical student here at UW on this new at the time campus. And that is, I've observed that we've evolved to a very transactional understanding of healthcare. We've evolved to thinking it's all about tick boxes and bullet points and the documentation by template. Any doctor can round on the patient any given day. Any clinician can be on the other side of the telemedicine screen. And any resident can cover continuity clinic without even recognizing the irony in that statement. But I believe at its core, our work is relational. And that we are better diagnosticians if it is founded on a relationship with our patients. We are better at working the system if we are working in teams where we have invested in those relationships. And so I think we need to consciously build the infrastructures, the physical space, the staffing models, the payment models that will support and sustain those relationships. I mean, this is something very distinct from relationship-centered care, which depends on heroic physicians to compensate for an external environment and maintain relationships. What I'm speaking about is where the entire system is intentionally designed to support relationships. And I'll give some examples of that. And I believe that that is the shortcut to achieving the quadruple aim. The quadruple aim being better care for individuals, better health for populations at lower cost, while supporting a thriving workforce. So what I'd like you to take away from this talk today is about the power of connections and how important it is that we build systems, that we build workflows, that we build physical spaces, that we build policies and practices that strengthen all of those connections, the hidden architecture within healthcare. In fact, I think that's the secret sauce of healthcare, and I think it's time for us to bring it out into the open. And that, I think, will be the source of both individual resilience to get through challenging moments, but of systems resilience. So I'd like to refer you to a paper and to acknowledge my co-authors, Dr. Tate Schoenefeld, who's the Chief Wellness Officer at Stanford, and Dr. Alexander Risto, who is an early career physician, for a commentary that we published in Mayo Clinic Proceedings, when was that? Last December, on the radical reorientation of the US healthcare system around relationships. And I refer you to some of the tables there because we have 3 tables with a lot of detailed examples of how you might manifest that aspiration of redesigning the system around relationships at every level. And then I'm going to leave you with the 6 takeaways for how we might redesign the system for whole caregivers and whole care. So the first is to prioritize relationships, and we'll spend most of our time talking about that. The second, you might be surprised at, and that's to maximize the role of nursing. To maximize the role of nursing, particularly in the ambulatory space where we've really evolved away from leveraging the power that nursing can add. But to do that, we need to have the availability and the affordability of nurses then to be our clinical partners in the ambulatory space. Reduce operational waste. I'll give a few examples to support my claim that I believe most physicians in most specialties and in most settings can save 3 to 5 hours a day, every day, by re-engineering the way the work is done and by more strategically delegating work to that upskilled team. The fourth is to reduce regulatory burdens, and I'll share some ideas on that. But I'll be very clear, I think we need to readdress a non-evidence-based policy and practice of prohibiting verbal orders. Team order entry, I believe, is one of the most effective ways to improve efficiency and improve teamwork. The fifth is to move more decision authority to the physicians who are closest to the patient. We now have the most highly trained individuals within the healthcare organization, often working with almost no control over the minute details of their daily life, their daily work life. And then finally, I think we need to invest in the science of practice. We invest a lot in new tests and new technologies, but we haven't been investing in the science of practice itself. I'm going to start with an example that I suspect is common in most healthcare organizations around the country. This is a patient and she's calling in and she says, I have a problem and I'd like to see Dr. Sarah today. This might be her internist or cardiologist or pulmonologist, could be any particular specialty. The receptionist says, oh, her last appointment just filled, but her colleague, Dr. Bresnik, can see you this afternoon at 1 o'clock. In most settings, that would be an overwhelming success. Patient had a problem, she was able to be seen that very day by someone in her specialty. Many systems would aspire to being able to meet that, but I'd say that's not really as good as we can do. So she sees Dr. Bresnik and he struggles to get modestly up to speed with her medical and surgical history, but he has no social context for her, doesn't really know her. Meanwhile, her doctor is in clinic, just down the hall, busy typing, down the hall, entering all those orders, down the hall, doing the visit note documentation. And we know for every 1 hour of direct face-to-face time, our physicians are spending 2 hours on EHR and desk work. So if we can reverse that, we can have a lot of time that we can reclaim and devote toward prioritizing continuity. So Dr. Bresnik sees this patient, but orders more tests than Dr. Sarah would, spends more time. What might have taken her personal doctor 10 or 15 minutes is taking him 40 minutes. And then not only does he do sort of a superficial evaluation and some temporizing measures, he arranges for her to be seen by her regular physician in 3 to 5 days. And so that's doubling the work for the patient. It's doubling the work for the reception staff. It doubles the work for the billing staff. It doubles the work for the rooming staff. So it's not only adding additional work to our physicians, but it is adding additional work to the whole system. The whole engine takes twice as much work to see the same number, care for the same number of patients. And so that gets to this vicious cycle where that lack of prioritizing continuity contributes to waste, which then reduces capacity and contributes to more waste. But we can change that into a virtuous cycle. If we absolutely prioritize continuity in the way we set up our scheduling, in the way the staff interacts with the patients and interacts with the clinical staff, in our technology and in our scheduling system, if we prioritize that relationship, we combine that with operational efficiency, we reduce the total amount of work it takes to take care of a population of patients. Therefore, we have greater capacity and we can have greater access and we can fuel that virtuous cycle. And I would say that relationships are what fuels that virtuous cycle and that relationships are our superpower. There is a wealth of evidence that care is better when there's continuity, whether we're talking about continuity over a small window of the hospital stay, whether we're talking about continuity over a year, or whether we're talking especially about continuity across the inpatient and outpatient divide and over years. And I think we've collectively turned a little bit of a blind eye to the evidence of the value of continuity. Better quality, lower cost, fewer ER visits and hospitalizations, and lower mortality. Even in the ICU, when there's when there's continuity, fewer, less mortality. Continuity within our teams, lower cost, higher quality, less burnout when the same people work together. So I'm going to go over 8 system approaches for specific ideas, specific tactics by which we can achieve this strategy of prioritizing relationships. And again, I'll ask you to think about, well, what does that stimulate my own mind about how I might do something, or my unit might do something different to prioritize relationships. So first, continuity. We gave an example in the outpatient setting. I'll give an example in the inpatient setting in a minute, but what I'd also like to do is talk about the cost of the high cost of broken relationships. So we did this study using published data, CMS claims data and other published data, and worked with an economist who's now at Stanford to look at what's the cost to healthcare, to the healthcare purchaser, the payer, either the patient or their insurer, when they lose their primary care physician. And what we found was that primary care physician in the United States turnover is costing $1 billion a year in excess tests and treatments that wouldn't have been ordered had this been the patient's primary care physician that they'd had. But when that relationship is broken by virtue of physician turnover, it results in an additional $1 billion worth of tests and treatments that wouldn't otherwise have been ordered. And we can attribute about a quarter of that to turnover that's related to physician burnout. So here's the inpatient example. This comes from the Cleveland Clinic and their infectious disease department, where they have a one attending policy, where if you pick up the patient when you're on service, then you continue with that patient even for those days after you're on service. And it requires then some modification of the schedule post-service to accommodate that tail. But what it does is it reduces the total amount of work that has to be done by the ID department to care for their patients, because and this is how Dr. Rem at the Cleveland Clinic describes it, every patient I follow on the tail is one that my partner doesn't need to pick up. And there's so much knowledge housed in the relationship that there's so much less work in maintaining that continuity until the time of discharge. Now, in your work environment, you may decide that the way to prioritize relationships is different, but it works for them. And it's one example of the kind of creativity that people are using to prioritize relationships. Okay, communication. This is something from my own practice in Dubuque, Iowa. My husband and I were internists at a multi-specialty clinic in Dubuque, Iowa, just across the Wisconsin border, with about 160 physicians and APPs. And we had a practice of 2.5 nurses per physician. So you can see the 2 of us and our 5 nurses there. And one thing we did is we had a welcome to our practice brochure. And it introduced our patients to every single person on the team and what their role was and what they can expect from the team, and also how they can interact with us, how they can achieve an appointment with us, for example, or if they have a question, what to do about that. And then when we would see the patient, if a rooming nurse had roomed the patient and my primary nurse hadn't met them yet, I would bring them forward. She would get up, shake their hand, and I'd say, this is my primary nurse, Deb. She'll be your main contact person. If you have any questions between appointments, I'd like you to give her a call. I wanted patients to have a name and a face to put together so that they had no barriers to reaching out if they had a need. This is a variation on that from Stanford. This is in the OR. And what they did is they simply put the name and the role type of each person on the surgical caps so that people could call each other by name. And what they found was that reduced the number of missed communications during the procedure. This comes right here from UW, from the family medicine department, where social connections were studied. And they found that as the density of EHR communication increased, the number of asynchronous messages that went around and around in the office, quality outcomes were reduced. Whereas conversely, when the number of face-to-face communications, the density of those increased, quality measures improved, hospitalizations decreased, urgent care visits decreased, and costs were reduced by almost $600 per patient per year. What about the physical space? This is from Health Partners in Minneapolis, where they found that when the physician and the rooming staff, in their case, a medical assistant, in our own case, an RN, when they were seated next to each other in a co-located space where they could speak to each other in small moments between other responsibilities, they saved 30 minutes of physician time a day. So when a call came in, the medical assistant could turn and ask that question and it could be answered. That didn't require asynchronous messaging. It also was an opportunity to build trust and reliance within the team and to continue to build the skill set of the support staff. Schedule. I think we have a lot, and I know it here at UW as a patient, and I know it from visiting other practices, and I know it from my own practice. There is a lot that can be done to improve the continuity of care and to improve our care of patients altogether by improving the science of scheduling. First, it's just the simple act of reappointing patients when they leave your office for the next appointment with an actual date and time. That requires the mindset of that. It requires having the proper staff to do it so it doesn't fall on the physician's shoulders, and it requires opening up the schedule for 15 months in advance, knowing that you'll have to reschedule a small percentage of that, of those patients, but that's much more efficient than having a tickler file and having to reschedule 100% of the patients. I also think we need to reevaluate central scheduling, that there is a lot of efficiency with local scheduling. When we have central scheduling, we cannot have the kind of personalized experience for the staff and for the patient, and a lot of little things fall through the cracks. I myself have experienced it here, where it took 6 touches to address the routine care that I needed, whereas a single reappointment at the time by a local scheduler would have been a single touch. And that's a lot of waste, and it's hidden. It's hidden within the system. And I don't think right now we are routinely looking at that hidden waste. I think it's time to rethink discharge clinics, where we have as a compensatory mechanism to the fact that we don't have access with patients' personal physicians for follow-up. So then we, instead of improving the systems to improve that access, we set up discharge clinics where a physician who has never seen that patient before, did not see them in the complicated hospital, and who will never see them again, sees them. And we can ask, what's the value of that, rather than investing those resources to support continuity, which supports efficiency. This is a simple measure that I heard of from C.T. Lin, who's the CMIO at the University of Colorado, and he's also a practicing internist. And he said a few months ago, we were given, as physicians, control over 1 appointment slot per session, over 1 20-minute slot per session. We could use it for working on our inbox. We could use it for seeing a patient who was calling in that day. We could use it for seeing a hospital follow-up. And that made a world of difference to their satisfaction, and it did not reduce their productivity. What is tragic to me about that example, it's a good example, let's do it, give physicians control over 1 slot a day, but that is control over such a minute portion of the day. It's very, very different than my own experience, where I had control over the entire schedule and the entire day. If we give physicians even that minor amount of control, it can make care better for patients and can make it better for everyone. All right, so let's talk about teamwork. And here I like to think about team size, skill level, and stability. We know that there are better outcomes for patients when there are stable teams, whether it's the same group of people working together in the OR, in the ER, or in the ambulatory clinic. And I've left some references there. but we're going to give the example here that's in the ER. And I like this example because of the methods. They analyzed EHR event log data, and through that analysis could identify the strength of the relationships of the people caring for an individual patient who presented with a stroke. And what they were able to find was that door to needle time for the TPA was shorter if those nurses and physicians had worked together previously in the past. And it was even shorter if they'd worked together previously for a patient with stroke. So there is so much that's important in how we work safely together and how we work efficiently together, that it resides within those relationships. And this study had been done, it was done at Stanford, UCSF, and Kaiser Permanente of Northern California across 24 emergency rooms. This is from Wisconsin. This is from Bellin Health in Green Bay. And this is an advanced model of team-based care with in-room support. And in this model, there are 2 upskilled MAs per physician. The MA stays with the patient from the beginning to the end of the appointment. In the first component, the MA is doing agenda setting and closing care gaps, giving immunizations, for example, setting up for the colonoscopy. Then when the physician comes in, the assistant, the medical assistant in this case, is doing real-time order entry, reducing the cognitive load on the physician who doesn't have to then try to remember it later on or do multitasking. And then real-time visit note documentation. And then when the physician leaves, the MA stays behind and operationalizes all the decisions that were made, makes sure that the patient has all the self-management support that they need, while the physician moves on to the second patient with a second MA. Bellin Health began this within their family medicine department and gradually spread it across all the physicians in their organization. They were able to compare those who were in it to those who were not. After the first year, higher quality metrics, lower per member per month cost in their ACO, and additional $724 of revenue into the organization from closed care gaps. The interesting thing for me is we went to Bellin many years ago to videotape this example. We went around the country videotaping a lot of practice innovations for practice efficiency. And so I was talking to this patient who had agreed to be videotaped during her visit. I was talking to her before we started, and she said, you know what I really like about this? What I really like about this model is now I get Dr. Jerzak all to myself again. I think as patients, we recognize what's lost when our doctors are doing this while we're telling them something about ourselves. So again, I think we can save 3 to 5 hours a day by some of the practice fundamentals. And you can learn more about the practice fundamentals, as was mentioned, through Steps Forward resources. We have over 75 toolkits. We have webinars and podcasts and playbooks. We've had over 2 million unique users of those resources. They are actionable, practical, one-stop resources, stepsforward.org. And some of them are on the practice fundamentals. You can save 30 minutes a day by doing pre-visit lab, by arranging for the lab to happen before the visit so that you can talk about current results at the time of the visit and you don't have all those loose ends coming in after the visit. You can shrink your inbox by doing pre-visit lab. So we have playbooks. We have this is the Saving Time playbook. And what it is like the Reader's Digest version of 6 to 10 of the toolkits. So this one on saving times starts with stop doing unnecessary work, highlights one of my favorite toolkits, getting rid of stupid stuff. Talks about incorporating the practice fundamentals. And then also, how do you communicate with your leadership to help bring them on board to understanding that investing in the teamwork to reduce waste, to improve efficiency, to save time has benefits for all. And we've got podcasts and webinars. So what about technology? I believe we can also leverage our technology either to hinder relationships or to foster relationships, and how we intentionally design it, not just how Epic designs it in Verona, which is important, but how it's implemented at local institutions and how it's regulated at those institutions as well as elsewhere. So one thing that I have observed over my long career is that I had 16 years in the paper world. Much of that time I was looking forward to, oh, how much better things will be when we don't have to handwrite every single medication and read each other's handwriting and that sort of thing. And then 16 years with the electronic health record, where it was wonderful that we did not have to try to decipher what someone was writing. But it wasn't nirvana. In fact, there were many things that became much more hazardous after the implementation of the electronic health record. And I think at their core, many of those things shared the fact that there was this great work transfer. That work that was previously competently done by members of the healthcare team, by the medical records clerk, the transcriptionist, the pharmacist, the ward secretary, had now become the work responsibility of the physician. And we took that on incrementally. We took that on in part from the iron dock mentality, but it led to that time pressure, that time compression, that 2 hours of EHR work for every 1 hour of direct face time. And I think it led to something we've not really been focused on, and that is the cognitive overload. We can't multitask, we only task switch. And when we task switch, we have attentional blinks and we don't catch all the clues our patients are sending us. And when we are cognitively overloaded, our working memory shrinks. And so we are working in a more hazardous environment. But when, for example, when you leave one patient's room and you have done all the documentation, all the orders are entered, all the labs have already been reviewed, and you are fresh to move to the next patient, your working memory is wider and the safety hazards are less. So what's else on technology? Well, the inbox. Any of you that have a patient panel or who are involved in continuity of care will know that the inbox has become a much bigger issue. It's become a second job for many of our physicians. And that has been exacerbated by the COVID pandemic. This is data about one aspect of the inbox, patient medical advice request, PMARS. And this is looking at the entire US user base of Epic. And what researchers were able to document was right at the onset of the pandemic, there was a sharp increase in the number of PMARs that patients were sending. And it never went down. It has continued at the same rate. Our visit volume has gone back up to where it had been before, but our PMARs have stayed up. If you're at the top quartile of inbox messages from your patients, inbox messages of all types, you have 6 times the odds of burnout if you're compared with being at the lowest quartile, just underlining the impact that this second job is having on our physicians. I've started to say physicians don't leave their jobs, they leave their inboxes. We certainly know that physicians cut back to part-time, in part as a way of managing the inbox. But the problem is, that's a little bit of a trap, because when you cut back on your clinic hours, but you do not cut back on your patient panel size, you just push more work to be done virtually. And so actually there's data that shows that physicians who are working 80% time have an absolute higher inbox volume than physicians who are working 1.0. So what can we do? This is Dr. Jane Fogg, who was a leader at Atrius Health, a large health system in the Boston area. She now is on my team at the AMA and helping us with the work that we do to improve efficiency and reduce burnout. She led a 5-year initiative at Atrius to reduce their inbox volume. And they've been able to reduce CC charts by 40%, reduced the number of scanned documents by 98%. They reduced the ADT notifications by 100% by putting it into a dashboard so you pull for it rather than push. You can get 6 ADT notifications for every hospitalization for a patient. So they were able to ultimately reduce the total volume of inbox by 25%. So she and I, with others, put together an inbox reduction checklist, a 2-pager on things that every organization can look at and decide, are there things we can do to reduce the volume of the inbox? She also wrote this much more detailed toolkit on how to reduce the inbox volume, how to set up the governance structure for having this kind of initiative. It's full of granular details. Highlights, DC the CC. If you're going to CC a note, you can't just CC it, you have to CC it with a customized message about why you're sending that to another physician. After that was done, one physician who said, I used to spend all day Saturdays reading over all those CC'd notes, looking for something. Now Saturdays I spend with my family. You order it, you own it. It might seem like it's a safety issue to have multiple physicians receive the results of a test you order, but that ambiguity about responsibility actually is a safety hazard. So you order it, you own it. You don't CC that to anyone else. And then 90+4 on the prescriptions, 90 days plus 4 refills on all chronic stable medications. You still see the patients as their conditions require, but you don't double and triple and quadruple the work of managing those prescriptions as they randomly come due throughout the year. And you don't use the prescription as the enforcer for compliance with visits follow-up. So, collegiality, morning huddle. This is in Boston, just a stand-up meeting. Who's in, who's out today, who might have some special needs, can be a 5 to 10 minute meeting. Combine that with team meetings, which you may have every couple of weeks to help refine the workflows with the people who are doing the work. Sludge. This is my favorite strategy, and the tactics within this can be getting rid of stupid stuff. There is so much waste within healthcare. If we can begin to extract some of that waste, our capacity is greater. We'll have more breathing room to have relationships with each other, to have relationships with our patients. So here's Dr. Melinda Ashton, who wrote the New England Journal of Medicine article on getting rid of stupid stuff. And she then wrote our Steps Forward toolkit with a very practical step-by-step approach, how you might develop a similar initiative at your organization. We developed a 2-pager, the de-implementation checklist, suggestions for what you can do to de-implement policies that may have made sense at one point, but may never have actually lived up to their expectation or have outlived their usefulness. We sent that to the Joint Commission where they reviewed it. We made a few minor tweaks. So we know that it's consistent with Joint Commission standards and therefore with CMS policy. We have an initiative at the AMA called Debunking Regulatory Myths. That's a companion to that. We have now 21 myths that we've published online, and we state the myth, state some of the background about that, and then we point to the place in the federal language or in the Joint Commission that debunks that myth. And you can print those out as PDFs and take them and use those to support conversations that you might have with your unit leaders, with your compliance professionals, with whomever. So I want to end with a couple of thoughts. One is there are some additional myths, I think, that are pervasive in healthcare. One is that a clerical task is safer if it's done by the physician. And the costs of that are enormous. We have stolen time from patients with that belief that something is safer if it's done by the physician. We have stolen time from children, from their parents, when their parents are physicians, by that belief. And it's absolutely not evidence-based that a clerical task is safer. In fact, I would submit that clerical tasks are less safe. In my own practice, my nurses wouldn't allow me to go to do any order entry, because when they're doing order entry, they were doing just that. If I were doing it, I'd be doing multiple things at the same time. So what's the cost of mandating physicians as the clerical individuals keyboarding in the orders? Just in primary care, there are 250,000 primary care physicians around the country. Data from researchers at the UW suggests that primary care physicians in the past were spending 41 minutes a day on order entry. So let's conservatively drop that down to 30 minutes. And then we'll put that as 30 minutes is one additional patient. That's the capacity across the US for 50 million more primary care visits a year. Imagine the improvement in the healthcare experience, the quality, and the cost of healthcare if we had access to 50 million more primary care visits a year, or if, stated another way, 20 million more people had access to primary care. And that's just the tip of the iceberg of the kind of waste that we have built into the system. So if you're interested more, I really like this term that Clay Christensen has of solution shop work. The idea there is that ideally organizations and industries will have their highest trained individuals do the work that only they can do, the work for which they are uniquely trained, which across industries is to solve unstructured problems. In healthcare, I've changed that to both solving unstructured problems and then building relationships with our patients and with our teams. And so with a colleague, we wrote a paper in the New England Journal, a commentary on production line versus solution shop. And I believe we have our physicians now doing much of their day on production line tasks, standardized predictable tasks, clerical tasks, and diverting it away from solution shop work. Okay. Also, I think we have an opportunity to invest more in practice science. We have a $4.3 trillion industry that is underperforming. And I believe it's underperforming primarily because of the delivery model on which it is founded. We invest collectively from private and public sources over $240 billion every year researching new tests and new treatments. And I'm really glad that we do. But we invest less than $500 million, so a tiny fraction of that total amount, on the science of practice, on the delivery model itself by which to choose whether to deploy or wisely choose not to deploy tests and treatments. So I just heard this. I was at a Princeton conference a couple of weeks ago, and Atul Gawande spoke, and he said, and he didn't make this up, I think someone else did, we have Star Wars technology on a Flintstone chassis in the US. And I think we do. We have a Star Wars technology, but we deliver it on a delivery model where we haven't invested in the practice science to know what are the best team structures, what are the best scheduling approaches, what's the best way to handle lab for chronic illness care. That we haven't invested in. And yet, there's a lot of opportunity there. So let's go back to those 6 takeaways that I'd like to leave you with, that I think when we're thinking about improving the healthcare experience, particularly for all of you in the back who've got a lifetime of in this fabulous profession, what do we need? I would suggest we need to systematically build all of our infrastructures to prioritize relationships with each other and with our patients. We need to maximize the role of nursing, again, given availability and affordability. Reduce operational waste. We have the opportunity to save 3 to 5 hours a day for most physicians in most specialties. I'll just underline that with an asterisk. At UCLA, they found by doing that in-room clerical support, they were able to save 3 hours of physician time every day of geriatrician and general internal medicine. So there's a lot of operational waste. We can save that 3 to 5 hours a day. Then reduce the technology burdens. We've got problems that start with federal regulation. They're enabled by the electronic health record, but they're exacerbated by the over-interpretation of those regulations at the local level. Push more decision authority to the people closest to the patient, even if it's just control over 1 slot per session. And I think we can go further than that. and then invest in the science of practice. So with that, I want to thank you for your attention, and I'd like to have a conversation. I think we've got a little bit of time that we can hear your thoughts, your questions.
Thank you very much, Dr. Sinsky, for these practical potential solutions offered. I learned a lot. So with that, questions, Dr. Schnapp?
Great. I really enjoyed the talk, and everything you said resonates. Question: with the transition from many roles to hybrid or out of the office, how do you facilitate that collegiality, that team building in that setting?
Yeah, I think that is a challenge for all of us. And honestly, I don't know. I think we are fooling ourselves if we think we can replace the benefits that happen in face-to-face connections with remote work. And I say that as someone who does a lot of remote work, right? But yes, we can have hybrid where we're together sometime and we're not together other times. But for nurses to really be delivering good care to patients, I think they need to be connected to the APPs and physicians who are delivering that care and to the patients. And if we have someone only on the other end of the telephone, I think we're just not going to get the value out of it. And so we should study that and find out. But I think if we study that, we'll find out some things like we've learned with telemedicine. We just published a study that the more telemedicine you do, the more pajama time you have. That is, the more work outside of work you do, work outside of your scheduled hours. So I think there's just a world of things that we don't want to assume that if something's done remotely, it's more efficient. I think there are times where we're finding that it's actually less efficient to do that.
Hey, Christine, Betsy Trowbridge.
Hi, Betsy.
Thanks for the great talk. When you look at UCLA and Bellin, what has happened to their care models post-pandemic as workforce has changed?
Right.
So I'm just wondering, you have your pulse on everything across the country. How are people addressing that? How are they hiring medical assistants? How are they hiring RNs? Because we need some tips in that area.
Right. And you're not alone. Bellin's not alone. University of Colorado that also moved to this model. All are struggling to hire enough medical assistants or nurses. So let me tell you what I know people are doing and then what I recommend. I know people are providing career pathways and career ladders so that when you become a medical assistant, it's not a dead end, barely minimal wage job. Before I came to speak here a number of years ago, I stopped to get my hair cut at a cost cutters just randomly. The person who cut my hair had been a medical assistant at UW. She made more money at cost cutters. She liked her work at UW well enough, but she also needed, the financial support. So having a career ladder is important. That's something that the University of Colorado does so that you can advance as a medical assistant. Having a training pathway so that people who are already employed here, perhaps as receptionists or patient service representatives, can then be trained on the company dime, if you will, to become medical assistants. And I think you're doing that because when I had an appointment, the medical assistant that I had, she was particularly good. And I was talking with her and she was becoming an RN on a similar kind of program. Now here I'll be a little controversial. In Dubuque, we hired RNs. We had no trouble hiring RNs. I looked around, we have 10 community colleges within a 100-mile radius that train associate's degree RNs. It's a 2-year training program. We have a $4.3 trillion industry that is teetering on the backs of not having enough trained support in our ambulatory spaces. We can fix that problem by ramping up the training of a training role that takes 2 years to get that degree. Those individuals pass their RN boards at the same rate as BSN trained nurses. So I think if we really want to solve the problem, we have to look at some of the solutions that will require interprofessional collaboration at solving the problem. We have to ask our nursing colleagues to be part of the solution in terms of this. And it's an excellent entry into the middle class for individuals who don't have the ability to invest in a 4-year degree. So I really think there are many pathways that people are doing, but everybody is struggling with that issue. And yet, when we had a nursing shortage, the CEO of an organization told me, there is no amount of money we will not pay a traveling nurse to keep our ORs running. And those traveling nurses were being paid salaries of an orthopedic surgeon. So if we can do that, I think we have to say it's a priority that we have continuity in relationships. And one of the things we need is team skill level, stability, and size. And we can't do that on minimally waged individuals.
Thank you. Question from the remote folks, again, about models of care. My practice would be so much more efficient and so much easier for me if I had 2.5 nurses, including a primary nurse who knew all my patients and my practices. At this point, for a full-time physician, I do not even have a 1.0 FTE nurse, much less a primary nurse that knows my patients and practices to start with. How can we justify staff at this level?
I didn't hear that. How can we justify staff? Oh,
At this level.
Well, so yeah, I realize 2.5 nurses per physician, that's a non-starter. Nobody's going to go there as the first move, right? I mean, that's just, it sounds so ridiculously unrealistic. I paid for that out of my own productivity. We worked in a model that was a productivity-based compensation model. Their salaries came out, whatever was left came to me after other overhead. It was absolutely well worth it. It was well worth it for my own personal professional satisfaction, but it also resulted in more RVUs, which only makes sense, which that individual recognizes. But the way I would say is, I think realistically, if you had one RN for 2 physicians and it was the same RN every day, it has to be the same RN every day. And then you had an additional MA per physician. That would be a really wonderful way to start. So you had 1 MA and a half of a nurse per physician. You were in a unit, whether it's virtually or physically structured, 2 physicians, 1 RN, 2 MAs. That, I think, is a powerful model that will reduce turnover, improve satisfaction. And that stability is so important. You cannot treat individuals like widgets and just slot them in to make the schedule seem more efficient, because the contribution is so much more when you've had a chance to work together. So North Shore in the Chicago area published a study where they were able to increase the output of the team without increasing the number of MAs. And what they did was they simply prioritized the MA physician relationship, that it was the same pairing every day. And by that, in those pairings, they had 11% higher RVU generation, just by pairing the same people together. Not by increasing the skill level, but of course the skill level of those MAs improved, right? Because I'm going to invest in training that person. I'm going to invest in having them understand why we do what we do. And so they will function every day at a higher and higher level if they're the same person every day. If they're just there once in a while, then it's futile to do that kind of training. They had better quality outcomes. And then I just had a chance to email with Nadim Abawi, who is the internist who led that initiative. And then COVID happened. So in their clinics that had gotten that stability built in, they have no retention problems with their MAs. They are fully staffed. Contrast that to the clinics within North Shore that didn't have that stable pairing built in, and they're short-staffed because they can't hold on to MAs. Well, we stay because of relationships. We stay because of pay, but we also stay because we work with each other. We've got teamwork, we've got friendships. So we've got the opportunity to be intentional about that. And one way of being intentional is those pairings.
Thank you. Another question. Some hospitals have a policy that a physician will be decredentialed if they do not close their charts in so many hours. What is a more constructive approach?
Sounds like that's a pain point. Okay, yeah. So what I'm going to say is let's turn it around and use that metric of chart closure. And I would mimic this. Boston Medical Center has done this. They have a measure. I think they call it their workload measure. They used to call it dock leg, but it's the time between when the chart was open to when it's closed. And they use that as a proxy for cognitive workload. Think about that. If you're carrying on your back all through the day, all that unfinished business, your backpack gets heavier and heavier as the day goes on with all that unfinished work. And if you can finish that in a short period of time, all the better, right? And of course, if it extends over days and days. So instead of using it as a metric that is assessing the functional ability of that individual, let's use it as a measure that assesses the functionality of the unit or of the healthcare system. That the system is responsible for creating the conditions where that work can be completed, where today's work can be done today. So that's how I might look at that.
And another idea on this same topic, what about some sort of carrot, then a stick approach? Any thoughts?
Carrot and stick about closing the charts?
Yes, offering carrots. Patient safety, incentives.
I guess I'd also encourage people to do sort of a root cause analysis about why the charts aren't being closed. I don't want to present myself as an expert on chart closure. It's just not a thing I've spent much time with. It was never a thing for me because I closed every chart before I went to the next patient. So
one last online question, and the rest of you I encourage to stay if you can to talk to Dr. Sinsky. Amazing talk, really eye-opening. Thank you for being here. How much of an impact do you think physicians shortages makes in this space? Do you think we need to push for increased funding for residency and medical school slots to improve our ability to be nimble and make these changes?
So there is a physician workforce shortage. And one of the things we did recently, it was just published this month, was a paper on work intentions of physicians and burnout. And I want to make sure I'm saying this correctly. 24% of physicians indicated an intention to leave in the next their organization in the next 2 years. That was pretty similar to a decade ago when we also measured intent to leave. But we measured intent to reduce output, to reduce clinical time, to cut back. And that had doubled from 10 years ago and was over 40%. We know from other studies that about 1/3 of people who indicate their intention to leave their organization will leave. And so across the US, if 1/3 of people carry out their work intentions as reported in our survey, and it's a national survey, standardized methodology, et cetera, that would be the equivalent of losing 20,000 physicians. That is the exact number we train every year across all the medical schools in the country. So yes, we can train more medical students. That's a really long pipeline, and it's an expensive pipeline if we're losing the same number every year at the other end. And any investment in all those practice efficiency, organizational culture, all those initiatives to reduce that burnout, to reduce that early departure or that partial departure by going to part-time, I think is good for all.
Thank you all. Thank you, Dr. Sinsky. Very
you.
enlightening
Thank you.
talk. Thank you for coming.